All right. Thank you for the introduction, Dr. Staudinger. My talk is going to be about the role of fructose metabolism in the pathogenesis of non-alcoholic fatty liver disease. So let's go ahead and get started. So this is just going to be my outline. This is what we're going to be talking about today. We're going to start off with some background of NAFLD. And just a quick disclaimer that you're probably going to hear me reference this in a couple of different ways throughout this talk. You might hear me say NAFLD, you might hear me say fatty liver disease, or you might hear me say out the word non-alcoholic fatty liver disease, or I might even say NAFLD. Just remember that regardless of what I say, I am going to be referencing the same thing. And so for background, we're going to begin with some epidemiology and the healthcare burden. Then we're going to move on to the pathology, but don't worry, we're not going to dive too deep on that. Then we're going to move on to fructose metabolism overview, and we're going to talk specifically about what is fructolysis, other than an odd-sounding word. Then we're going to move on to the meat of the talk, which is going to be contributory mechanisms of fructose metabolism, these specifically being insulin resistance, Denova Lipogenesis, and the gut microbiome. Then we're going to finish off briefly with some clinical implications. All right, so let's go ahead and get started with the background. So beginning with epidemiology and healthcare burden, non-alcoholic fatty liver disease is the most common chronic liver disease in the world. It has an international prevalence of about 32.4% and a higher incidence in males. Now, 32.4%, this is nearly a third of the world's population, and this is likely more prevalent than a lot of people recognize, so this is a very important disease. NAFLD is closely correlated with obesity. In a study that was done in Europe and the United States, 87% of patients who were diagnosed with NAFLD were obese. However, there is also a significant subset of individuals who have lean NASH. So NASH being non-alcoholic steatohepatitis. These were individuals who had a BMI of less than 25, but were also clinically diagnosed with non-alcoholic fatty liver disease. And this one is clearly uncoupled with metabolic disease because they were not obese. This one is thought to be more due to genetic factors or changes in the gut microbiome. It's still being elucidated as far as I could tell from the literature. And finally, in the United States, it is estimated that the economic impact of NAFLD and NAFLD-caused diseases is 103 billion US dollars. So this is an absolutely massive burden on the US economy. And just to clarify, NAFLD-caused diseases were defined in this study as hepatic steatosis, NASH fibrosis, NASH compensated cirrhosis, NASH decompensated cirrhosis, and hepatocellular carcinoma, just so we're all on the same page of what exactly was contributing to that number. And also quickly, you may have noticed that I said hepatocellular carcinoma. As we all know, there are several things that could cause hepatocellular carcinoma, but NAFLD is actually a significant contributor. So I think this data is pretty good. All right, moving on to the pathology of NAFLD. So NAFLD is going to be a spectrum of disease, and the first stage of that is going to be steatosis. Steatosis is defined as when liver mass is greater than or equal to 5% fat. And this will be diagnosed on MRI or CT. MRI is the gold standard. Of course, when you're going to be diagnosing someone with steatosis, and specifically non-alcoholic fatty liver, you have to exclude alcoholic and viral causes. The next stage of the disease is non-alcoholic steatohepatitis, or NASH, and this is going to be characterized by fibrosis, which is reversible, and inflammation. This is going to be diagnosed on biopsy in contrast to steatosis. And there's going to be kind of two subsets or two substages of NASH. This is going to be compensated NASH, which is basically just a patient who is still asymptomatic, which I think is pretty remarkable that someone can be walking around with an inflamed liver that is beginning to accrue fibrous tissue and a significant portion of fat, and they still won't show any symptoms at all. Decompensated NASH, this is going to be when that same patient begins to exhibit symptoms, and more prominent symptoms would be examples like abdominal pain or jaundice. And then finally, our last and most serious stage of the disease is cirrhosis, end-stage liver disease. This is going to be characterized by irreversible fibrosis and regenerative nodules. Some common complications of non-alcoholic fatty liver disease are going to be hepatocellular carcinoma, cardiovascular diseases, and several others like hepatic encephalopathy. Now, if you'd like to direct your attention to the right side of the screen, I've just got some pictures and cross sections of the liver to just show the distinguishments of these substages of the disease. This top one is going to be representing steatosis. You can see these huge fat droplets accumulating within the hepatocytes. This is actually going to be called balloon cells. This middle image here is going to be a picture of NASH. You can see that you still have those balloon cells present, but you're also starting to get that fibrous tissue beginning to be laid down. And in addition to those two features, you'll start to get something called Mallory-Dink bodies, which are going to be accumulations of an inflammatory protein of intermediate filaments. So that's that inflammatory characteristic there. And then finally at the bottom here, I've got a cross section of a cirrhotic liver. It's not as close up, but this one I think does a good job of showing that massive amounts of fibrous tissue that have been laid down and how it begins to kind of separate the healthy parenchyma of the liver, which actually gives the liver its nodular appearance. All right, so back to the outline, just to show us where we're going. So we just finished the background of NAFLD, and now we're going to move on to a fructose metabolism overview. So fructose, just a quick reminder of what fructose is. It's one of the main monosaccharides. It's going to be found in sucrose along with glucose, and it's also going to be found in high fructose corn syrup, and sucrose is just regular table sugar, just so we remember what exactly we're talking about. And the reason I wanted to include an overview of fructose metabolism is because a lot of people are pretty familiar with glucose metabolism, especially glycolysis, but maybe people aren't as familiar with fructose metabolism, so I thought it would be good to give a quick review on it, especially since fructose is unique. So fructose is metabolized differently than glucose. And how is it metabolized differently? Well, fructose is going to bypass the rate-limiting steps in glycolysis. These are going to be the enzymes, if we all remember basic biochemistry, of hexokinase and PFK1. Fructose skips right by them in an unregulated fashion, so we don't actually get to control how much of it comes into the cell. It has its own set of enzymes, as well as fructose is not responsive to insulin. So it doesn't matter if you have other nutrients present or what sort of metabolic state, both being fasting or postprandial, it is not going to affect fructose metabolism. Also, 90% of fructose is cleared by the liver and small intestine on first pass. This means that very little fructose is actually going to make it to caval circulation, and skeletal muscle and adipose tissue in the brain will actually very rarely see fructose. So they don't really have to worry much about how its metabolism will be affected there. And finally, fructose is primarily a substrate for gluconeogenesis and Denova Lipogenesis. So unlike glucose, fructose isn't really burned for its caloric energy. We actually use it more as a carbon backbone for some other molecules. And now, if you'd just like to look at these pictures down here, I thought it would be helpful to include molecular structures of both glucose and fructose so we can see their differences. Glucose and galactose are pyranoses. They are six-membered rings, but fructose is actually a furanose, meaning it's a five-membered ring. And now, this may seem like a subtle difference, but that's all the difference it takes for it to be metabolized in a radically different way, versus glucose and galactose are basically the same thing, and everyone kind of forgets about galactose, including myself. So next up, if you'd like to direct your attention to the right side of the screen, I think it's important, at least for what we're going to talk about later, to discuss what is a fructolytic intermediate. So fructolysis is what this word is referring to. That's just going to be the breakdown of fructose. And a lot of fructose metabolism will be shared steps with glycolysis, but at least the beginning of it is unique to fructose, and this is where the metabolic differences become so important. So just briefly, how it works is fructose can come into the hepatocyte, and then it will be acted on by the hepatic enzyme fructokinase, and this is going to generate something called fructose 1-phosphate, emphasis on the 1. This is only going to be found in fructolysis. As in glycolysis, we will be generating fructose 6-phosphate. And then further down the line of fructolysis, we'll also be generating glyceraldehyde. This is also only going to be seen in fructolysis. Versus in glycolysis, we will have glyceraldehyde 3-phosphate. So just remember these. We're going to talk a little bit about them later. All right, back to the outline one more time. We just finished fructose metabolism. Now we're going to get into the real meat of this talk, which is going to be contributory mechanisms of fructose metabolism. All right, getting started with insulin resistance, and specifically, fructose predisposes to metabolic syndrome. So metabolic syndrome is theorized to be the main cause of NAFLD, and metabolic syndrome is closely linked to insulin resistance. Just to briefly remind us, the 5 pillars of metabolic syndrome are hypertension, hypertriglyceridemia, obesity, and decreased HDL, and of course, insulin resistance. I wanted to include these just to show that these first 4 pillars can all be linked back to insulin resistance on its own. So there's a huge connection between metabolic syndrome and insulin resistance. What does this have to do with fructose? Well, fructose consumption and insulin resistance. Fructose will cause an increase in glycemic spikes. It will cause an increase in insulin requirements, and it can even cause an increase in visceral fat deposition relative to subcutaneous. So here's just some data from a study that I thought would help kind of show this point. This is a study that looked at insulin resistance in obese adults, and they measured insulin resistance by oral glucose tolerance tests. So these left 2 panels, A and C here, this is going to be our control group. This was a group of people who consumed glucose as 25% of their diet for 9 straight weeks. And this first panel is going to measure their glycemic load, and the bottom panel is going to be how much insulin was released in response to that. So as you can see, at the 0-week baseline and the 9 weeks end of trial oral glucose tolerance test, there's not a huge difference there. And same goes for the insulin response. And so basically, what is this saying? It's saying that if you consume glucose as 25% of your diet for 9 straight weeks, you're really not going to change or impact your insulin sensitivity at all. However, if you want to direct your attention to the right 2 panels, B and D, this is going to be our intervention fructose group. So these people consumed fructose as 25% of their diet for 9 straight weeks. And if we look at the glycemic response, you can see that there is a significantly big difference after 9 weeks of consumption compared to baseline. This means that just consuming fructose for that long, you will start to have increases in glucose. And then you can also see the insulin response also grew in a statistically significant fashion. The takeaway from this is simply that after 9 weeks of consuming fructose, you can develop some degree of insulin resistance that was not there prior. All right, moving on to our next contributory mechanism, we'll be talking about Denova Lipogenesis, and specifically fructose increases liver glucose uptake. So fructose metabolism increases de novo lipogenesis and directly contributes to steatosis and NAFLD. How does it do this? By altering glucose uptake. So if we all remember, the liver uses glucokinase. This is the liver's version of hexokinase. This is how it traps glucose into the cell. So when glucose is being uptaken, glucokinase will phosphorylate it to glucose 6-phosphate, and it will trap glucose into the cell. If glucokinase is not at the cell membrane, then glucose can simply slip back out into the bloodstream since it was not phosphorylated and trapped in cell. Glucokinase is regulated by sequestration, and specifically this is carried out by something called the glucokinase regulatory protein. So how does this work? Well, glucokinase regulatory protein, and I'll refer to that as GKRP, is going to be stimulated by fructose 6-phosphate. This is going to be one of the downstream products of glycolysis. So basically, once the cell has taken up enough glucose, you'll build up glucose or fructose 6-phosphate. It'll activate GKRP, and that will come back and inhibit glucokinase. So the cell stops uptaking glucose once it has enough. What does this have to do with anything? Well, fructolytic intermediates can actually impact GKRP function, basically interfering with the cell's negative feedback mechanism and allowing an unregulated entrance of both fructose and glucose into the cell. Now, what is the hepatocyte response to this increased glucose and fructose? Well, since we have an unregulated flux of fructolysis and we have way too much glucose entering the cell, we're going to have a lot of intermediates building up. And by this, I mean glycolytic intermediates. So we will get TCA overflow and NADH abundance within the hepatocyte. We're also going to get stimulation of acetyl-CoA carboxylase. This is the rate-limiting enzyme of de novo lipogenesis. Then we'll also get stimulation of something that's called carbohydrate response element binding protein, which is thought to have some role in stimulating the transcription of fatty acid synthase proteins. And this is specifically going to be acted on and stimulated by fructolytic intermediates. And now all three of these will directly contribute to fat droplet formation and the progression of steatosis within the hepatocytes. So now this next part you can probably zone out for, but I've always liked understanding the molecular mechanisms of how things work. So this is going to kind of be my attempt at elucidating how fructolytic intermediates impact GKRP function. So earlier I mentioned that GKRP is going to be stimulated by fructose 6-phosphate, and that's going to allow GKRP to sequester glucokinase away from the cell membrane and keep it on the nuclear membrane. So then when glucose tries to come into the cell, it won't be phosphorylated and it simply goes back out through GLUT2. But if you have the presence of a lot of fructose, you're going to generate fructose 1-phosphate. And fructose 1-phosphate is actually a slightly better fit for GKRP than fructose 6-phosphate. And the effect of having fructose 1-phosphate bound to GKRP as opposed to fructose 6 is that GKRP can't perform its function quite as well. So this prevents the sequestration of glucokinase away from the cell membrane and allows glucokinase to stay there, phosphorylating more and more glucose on its way in a sense, allowing the hepatocyte to take up more glucose than it otherwise would have if fructose was not there. All right, just a little bit more on Denova Lipogenesis. Blocking fructose actually reverses disease. Studies have shown reductions in liver fat mass with inhibition of fructokinase. If you're reading about this in the literature, you might see it listed as ketohexokinase. These are the same enzyme. So selective fructokinase inhibitor called PF-06835919 is a terrible name for a drug, but that's what they've got right now. It's listed this way in several studies. This is just something that can selectively inhibit fructokinase. If you'd like to direct your attention to this panel on the right side of the screen, I'll try and walk you through it. This was a study that looked at NAFLD patients, and they gave them this fructokinase inhibitor in 2 different doses, and then they measured whole liver fat mass change from baseline. So this is our placebo group. After a few weeks, they did show some decrease, but it was not statistically significant. This was our first treatment group with the fructokinase inhibitor. They gave 75 milligrams. They also showed no significant, statistically significant decrease. But then on the far right here, this is our 300 milligram daily dose of our fructokinase inhibitor, and they did show statistically significant reductions in whole liver fat mass. On average, those patients saw reductions in greater than 30% of their liver fat. This is wild to think that just blocking fructokinase and limiting fructose metabolism in the liver will not only limit increase in fat mass, but can actually show reversals. In a different study, this one done in rats, the same fructokinase inhibitor showed a reversal of hyperinsulinemia and hypertriglyceridemia. So just a takeaway, if you can eliminate fructose metabolism, you can potentially see some serious metabolic improvements. All right, and moving on to our last contributory mechanism, this is the gut microbiome. Fructose may indirectly cause hepatitis by inducing gut dysbiosis and barrier dysfunction. So just to quickly remind everyone what a healthy microbiome is, we're going to see things with increased microbial diversity and high amounts of short-chain fatty acid producing bacteria. Examples of these would be lactobacillus and bifidobacterium, those short-chain fatty acids being like butyrate and propionate, which are beneficial to the gut barrier. What is the effect of fructose on this? Well, chronic fructose consumption has shown a decrease in microbial diversity, a decrease in those short-chain fatty acid producing strains, and actually an increase in more harmful strains like proteobacteria and Bacteroides. They are more commonly producing LPS or lipopolysaccharide. What does this get us? It gets us an increase in TNF-alpha release and gut permeability. So increased LPS, TNF-alpha, and barrier dysfunction have all been linked with an increased hepatocyte ER stress, one of the markers of liver inflammation, which, if you remember, is one of the key characteristics of NASH, non-alcoholic steatohepatitis. And just to kind of show everything that I just said, but in picture form. If you have a high fructose intake, you're going to induce a gut microbial dysbiosis, and this is going to result in a decrease in butyrate-producing bacteria, so you're no longer getting the beneficial effects of those on the intestinal barrier, and you're actually also going to increase harmful strains of proteobacteria that releases a lot of lipopolysaccharide, directly damaging the gut barrier. All right. And so that's going to wrap up our contributory mechanisms. Now we're just going to finish off briefly with some quick clinical implications and some takeaways. So fructose is an important mediator of chronic liver disease. That's kind of the main takeaway of this talk that I wanted to give today, but also just the direct link. So 25% of people with NAFLD do admit to consuming one sugar-sweetened beverage per day, but I want to also point out sugar-sweetened beverages such as sodas are not the only source of sugar in the diet. So there's a huge link between fructose consumption and liver disease. Also, dietary changes and exercise are the current first-line intervention in patients with NAFLD, and rightfully so, those have shown the most improvement. And now I'm never going to lobby against exercise for anything, but for lifestyle and dietary interventions with NAFLD, it could be possible that diets may need to focus more specifically on fructose exclusion. You might be able to expedite some beneficial results if you do that. And then finally, fructokinase inhibitors may be a potential target for future pharmacologic studies. So far, I've only seen this inhibitor in trials and studies. I'd like to see what it could be utilized for in the future and how beneficial it could be, or if just another enzyme in the fructose metabolism pathway could also be investigated as a potential target. And then we would also have pharmacotherapeutic approach for non-alcoholic fatty liver disease in addition to our lifestyle treatments. And thank you.